My name's Dr. Julie Kim, and I'm a board-certified internist. I've been in practice for 24 years. I spent the first 14 years in primary care internal medicine, and back in 2012, I was introduced to this technology. And it really changed the way I looked at patients, how I thought about medicine, how I looked at symptoms and behaviors. And I saw patients who had struggled for years, and seeing changes in them in just a matter of 6 to 8 weeks was really eye-opening for me. And got really excited about the technology, joined Brain Treatment Center in 2013, have spent the last decade and will spend the rest of my career helping those who could benefit from this treatment. So we will go through a program agenda. First, I'll introduce neuromodulation to everyone. I'll pass it off to my colleague Haley, who will talk about what we do here at the clinic and the MeRT process. And then I will take it back over and talk about some studies that we've done with MeRT in ASD. And then we'll conclude with questions and answers and give you all an opportunity to ask any questions. So Brain Treatment Centers, we do a technology called MeRT. It stands for Magnetic E-Resonance Therapy. And the first center that used this technology was Brain Treatment Center in Newport Beach. The clinic opened its doors in 2008 and soon spread to where we are today in San Diego, as well as the location in Cardiff. Over the last 10 years, we've seen over 5,500 patients and used MeRT to treat those patients. We've seen a wide range of patients, including patients with PTSD, traumatic brain injury, depression, mood disorders, addiction, as well as others. And what we're going to mainly focus today is autism. More than 50% of our patients that we treat are children and adults with autism. And the prevalence of autism is rising. It's up 240% since the year 2000. 1 in 44 children are diagnosed with ASD, and that's doubled since even when I started, 2012, when I entered this space. The prevalence was 1 in 88. And there's a lot that goes into that increase in prevalence. Part of it is change in reporting, increased awareness in parents and providers, as well as earlier diagnosis of younger children. All of that has contributed to this rise. And it's not just in the United States, it's globally as well. And with that, we know that we need to do more research in this field, and we need to find new effective therapies for these children. The exact mechanism leading to autism are still not well understood. It's thought to be combined genetic and environmental factors that contribute to the cause of autism. The male to female ratio is 4 to 1, and the peak prevalence is the age 8 years of age. Neuroimaging studies show abnormalities in different brain regions in those with autism versus those without. And this is a fMRI study. fMRI stands for functional MRI. And basically it lights up in areas of the brain that are active. And you can see in the top, the autism group, you can see the circled area. There's a lack of frontal lobe activity in the brains of those with autism versus the control group. And not just in the frontal lobe, but also interconnecting in those areas, we see a lack of activity in the brains of those with autism compared to the control group. We know the front of the brain is responsible for certain things, including planning, thinking, judging, feeling, speech, and these are all domains that those with autism, they're challenged with. And these are the standard therapeutic modalities. Therapies including ABA therapy, speech therapy, OT, PT. These are all very commonly used to treat children with autism. Also, cognitive behavioral therapy is used to treat some of the behaviors, and also some medications. And and those are all very effective therapies, very useful in this space. And medicine tends to be very diagnosis-based. We take a cluster of symptoms, we match them to a diagnosis, and we treat that diagnosis with either education, medication, or therapy. And we wanted to take a different look and see if we can change the way we thought about these symptoms. Look at the brain as a treatable organ, find areas of disruption in the brain, and target those areas with a form of treatment to see if we can change the way the brain is firing and responding. And that leads us to neuromodulation. Neuromodulation refers to the emerging class of medical therapies that alter the nerve activity through targeted delivery of a stimulus. And so basically that means finding areas of the brain, targeting them, and trying to change the way these neurons or nerves are firing. There are two types. There's invasive and non-invasive neuromodulation. And MeRT is a form of non-invasive neuromodulation. This technology uses a non-invasive way to move these neurons and shift and change the way they're working. And so MeRT, again, stands for magnetic E-resonance therapy. It was developed by a group called Wave Neurosciences. They are also located in Newport Beach, right down the hall from our center up in Newport Beach, our brain treatment center. But the process is simple. We do an EEG, we map out the brain, we look for areas of disruption, areas of disconnect, areas that are underdeveloped. We take that information gathered from the EEG and we create a personalized protocol for each patient. And then we target those areas of the brain and we target it with a specific protocol, and we train these neurons to fire in sync with the rhythm that we are setting. And with this, we can deliver a non-pharmaceutical, painless model for these patients. And these are the EEG changes that we're seeing. On the left, these are the expected EEG findings. Brain activity between 8 and 13 hertz is what is normally resting brainwave activity. It's called alpha activity. And on the left, between 8 to 13 hertz, and it's highlighted in red there, we see the top graph represents the front of the brain, the middle graph represents the middle of the brain, and the bottom graph represents the back of the brain. You can see firing within this alpha range. In children with autism, we're seeing something different, and we see it across many. It's a very characteristic finding that we're seeing with autism. We're seeing areas of the frontal brain not developing this alpha rhythm. And you can see here on this EEG, the front of the brain, you can see a lack or a blunting of that peak in the front of the brain, as well as the central portion, and some development in the back of the brain. And this is an 18-year-old with a history of ASD. The first EEG on the left is the baseline. Again, highlighted is the area of resting brainwave activity called alpha. You can see a blunted peak in the front and central portions of the brain. And with treatment, we were able to develop some of that frontal alpha in the subsequent EEGs. And with these EEG findings, or with this EEG progress, parents are reporting changes in behaviors and symptoms as well. Parents are reporting improvements in sleep, imitating, improved eye contact, improved comprehension, listening, responding, as well as social awareness and verbal and nonverbal communication. And so I'm going to take a pause here and introduce my colleague, Kaylee. Kaylee is our clinician at our 3 centers, and she specializes in pediatrics. Prior to coming to Brain Treatment Center, she worked with new protocols to help children with severe allergies to desensitize them. So she came from a long space of new technology, new development, and it was a natural transition for her to come to BTC, use this innovative treatment to help our children with autism.
So I'm just going to detail the MeRT process a little bit further and show kind of what that looks like in our clinic. So the brain itself is a complex organ. Different areas of the brain are responsible for different functions. As seen in an earlier slide, different areas can control different things, like the frontal region controlling planning, judgment, emotional regulation, and speech. But the brain functions best when all those different areas work together as one unit. So when we look at brain activity patterns, we're looking at 4 main brain activity patterns that are based on the frequency of the neuronal action potential, or the firing per second. So the slowest brain activity pattern we see is called delta activity. It's 1 to 4 hertz frequency. It's the brain activity pattern we most often see when our brain is in deep sleep. Then we have theta activity, 4 to 8 hertz frequency. That's between our awake and asleep state, so first stages of sleep or drowsiness. Alpha activity, as Dr. Julie Kim mentioned, is that eyes closed resting awake state, that 8 to 13 hertz frequency. This is where our brain is actually at its most comfortable. So this is a big focus for us in MeRT, is on this alpha activity. And then we have beta activity. This is the 13 to 25 hertz activity. That's our eyes open awake active brain activity. So essentially the brain activity we're all exhibiting right now. So again, with the brain working and functioning best when all areas are working as one, we focus a lot on this global synchrony of activity to represent a normal brain rhythm. So essentially all areas of the brain are firing at the same frequency. When we see abnormal brain rhythm emerge, one area of the brain may be firing at a different frequency than another area of the brain. Thinking about it kind of like a radio frequency. If the front's at a different radio frequency than, say, the back of the brain, they're not going to be communicating at the same level, and it's going to diminish overall output and function. We do have some absolute contraindications to treatment. So before treatments start, you'll meet with the clinician and we'll get a detailed patient history to help determine if a patient is a candidate to safely move forward with MeRT treatment. Some of the absolute contraindications include a pacemaker or a defibrillator, some implants or hardware in the brain, so things such as coils, clips, shunts, filters, stimulators, other brain implants. We do have some exceptions, sometimes with different types of hardware or material can be exceptions. Again, the clinician will help determine what is safe for the patient to move forward with treatment. Pregnancy is an absolute contraindication. Magnetic dental implants. So dental implants in themselves are not an absolute contraindication unless they are magnetic. And then uncontrolled seizure activity. So like with dental implants, seizure disorder in itself or seizure history would not necessarily prevent a patient from moving forward with treatment. However, it does need to be in a controlled state. So again, that's something the clinician will work with you on in the initial visit to determine. So we start with an EEG and 1 lead EKG, and this is an overview of the MeRT process. So with that 1 lead EEG, 1 lead EKG and EEG, we start with that. The results of that are analyzed and a personalized MeRT protocol is generated based on those results. Then the treatment is given based on that personalized protocol, and then we repeat EEGs throughout to monitor progress and as well as to update the protocol as needed. So that EEG and 1 lead EKG together forms what we call a quantitative EEG or QEEG. So the recording of that is a process that takes about 20 to 30 minutes. It occurs in a dark, quiet room and it's painless. So sometimes patients with ASD don't enjoy or can't tolerate having something touch their head, especially for extended periods of time. So feedback we've received from parents who have children with ASD are sometimes preparing for the EEG recording beforehand can be helpful. So methods that they've suggested are practicing with like a swim cap at home, so they're used to having something tight on their head for an extended period of time, mimicking the EEG environment, so being comfortable in a dark, quiet room. And then we'll have the patient in the alpha state on the EEG, so that eyes closed resting awake state. So practicing having eyes closed resting for extended periods of time as well. And our neurotechnicians are very practiced at getting EEGs on patients with ASD, so they'll also work with you to get the best cooperation and EEG recording. So once that quantitative EEG is obtained, we utilize the results of that to see if there are any disruptions that could lead to depression, anxiety, or cognitive impairment. As mentioned, that waveform of greatest interest is that alpha waveform, which is that 8 to 13 hertz frequency. It's where our brain's most comfortable, which is also called our intrinsic frequency. So we tend to see pathology occur whenever there's disruption in that global synchronous activity of that alpha band. So, and what we're trying to do is to correct any alpha dyssynchrony that's being seen. So once that quantitative EEG is obtained, the results are generated to put together a personalized MeRT protocol for the patient with a precise amplitude, location, and frequency of stimulation. And what we're doing with that stimulation is essentially utilizing directing magnetic energy to nudge neurons or brain activity firing outside of alpha or alpha mismatch and push it toward the patient's intrinsic frequency. This is a process that we do daily, 5 days per week, Monday through Friday. So MeRT helps initiate the movement of the alpha wave toward the individual's intrinsic frequency. We repeat the EEGs to monitor progress and adjust treatment as needed. The tendency is to see gradual symptom improvement as those alpha waveforms are synchronized, with the most durability of change after about 6 to 8 total weeks of treatment, although that duration will vary from patient to patient. It's based on that clinical improvement in observed EEGs. So every 2 weeks, we'll obtain another EEG and have a clinical appointment and utilize those to determine what the best treatment course is for the patient specifically. Now, how a patient responds to treatment, when the response occurs, will vary from patient to patient, but there is opportunity with MeRT not only to see change during the treatment course, but even after the daily MeRT sessions are complete. Potential side effects or adverse effects of treatment won't necessarily occur, but if they do, these are the ones that we see. Probably the most common one that I have seen with our pediatric population is this transient hyperactivity. And I note the word transient in that if we see hyperactivity as a side effect of treatment, we will see it go away either with continued treatment or once treatment is complete. Other things that can occur are headache and fatigue. These are often mild enough that they'll resolve on their own, but you're welcome to utilize over-the-counter medications such as Tylenol or ibuprofen as needed to treat headache. Hypoglycemia can also occur, so we recommend eating a snack or a meal before treatment as well as after treatment. We have snacks available in our clinic as well. In my experience, I've seen our pediatric patients get to know that snack area very well, and it tends to be one of their favorite parts about treatment. With any of these side effects, we have the ability to adjust treatment as well to help alleviate any side effects. So either for the short term or the long term, we can make adjustments to best fit the treatment to help with any side effects if they are occurring. Now, there is a very rare risk of seizure. It's about 1 in 100,000 to 1 in 500,000. So as mentioned before, seizure history in itself does not mean that a patient will necessarily not be able to receive MeRT treatment. We do have a seizure protocol available. Again, that's something we will help determine at the initial visit. With our autism population, up to about 30% of our autism population may show potential abnormal activity or irregular activity on an EEG. This isn't necessarily indicative of seizure activity, but something that, of course, if it does occur, we will evaluate at the time. It won't necessarily mean we wouldn't be able to continue forward with treatment, but we will determine what's safest for the patient based on the overall clinical picture and move forward from there.
So there have been a couple of studies that have been done with MeRT and autism, or in autism. This is one study that was a randomized, sham-controlled, double-blind clinical trial. It involved 26 participants. Age range was the average age was 6 to 7. And this population of patients, there were 26 patients. They were randomized either to one group that received treatment and another group that received sham treatment. This was done for treatment or sham treatment was delivered for 5 weeks, and severity of clinical symptoms was evaluated by a CAR score, and CAR score stands for Childhood Autism Rating Score, and it was evaluated by a researcher who was also blind to who was getting treatment or not. After 5 weeks of treatment or sham, both parties were unblinded and both groups received treatment. And these are the results. The red represents the group that received MeRT treatment, and above the green dots there represent the group that received sham treatment, and these are the CAR scores. And so you can see that the group that received sham showed no change in CAR scores, whereas the group that received treatment showed a drop in CAR score. And then after the 5 weeks, when it was open label, both groups showed a drop in the CAR score. We did another analysis. We evaluated 167 charts of patients who received 2 months of treatment at our BTC Newport Beach and San Diego clinics. And these were all children with autism. 85% were male, 15% female. The average age, the mean age was 8. Overall, we saw, this was just a chart review, and we saw over the 2 months, we saw a 6-point drop in the mean CAR score in the 167 patients. And sometimes, I know we show you all these graphs and do all this talking, and sometimes pictures are worth 1,000 words. So this is something that an 8-year-old child before treatment had written out. And after treatment, parents sent us this. This was what he had written. And just showing these brains, as they start to organize, we start to see synchrony, organization, and thoughts and behaviors, and they just tend to resolve, and things become more clear for them. And I'm going to share a video with you. So this is a child, nonverbal, no eye contact, had some aggressive behaviors.
And then they had to go, they went on vacation, they went somewhere.
Okay, I get it.
And if we do miss one, or if he moves too much, we usually just add another one to the end.
This is after 8 weeks of MeRT treatment. He was more verbal, less aggressive, more social cues, and making eye contact.
Oh, that's not a T, it's a D. Kid. 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 Good boy.
And then this is 9 months after MeRT treatment. He had learned his ABCs, learned how to spell.
Rat. Good boy. Good boy.
Okay. And so our goal at Brain Treatment Center is to optimize brainwave function. And whatever comes from that, whether it be improved eye contact, increased awareness, improved confidence or independence, our goal is to give these patients and children tools to really reach their potential. So thank you for coming, and we'll just open it up to questions. Very good question. So it's usually a mild headache. When we stimulate, the coil causes contraction of muscles. We don't use our forehead muscles too often, so people feel a heaviness or a tightness sensation in their forehead. Usually after a week, people get used to it. We do say you can take Tylenol or Advil if needed, but most people, not enough to even take anything. But it usually does go away after the first week or so. Some people are really sensitive to the treatment, so sometimes we do have to reduce the intensity, and then as they get used to it, we'll increase it again. But it is our most common side effect, but it is very mild usually. You know, you're right. And I said there are so many factors contributing to that. Even in 2012, when I looked at the numbers when I was creating, it was 1 in 88. And 10 years later, it's 1 in 44. Yeah, and that's hard. I mean, and part of it is changing the way they're reporting and, increased awareness in the parents. And
so it maybe had been going on all along, but we didn't know?
Or
we thought that they were just bad kids?
No, not even bad, but just, yeah, on the milder spectrum. And so I think there is an increase, and I think there definitely needs to be studies done looking for causes as well as modalities for treatment. Yes, so TMS is repetitive transcranial magnetic stimulation, and it's a form of neuromodulation that's been around for over 30 years. In 1985, it was FDA cleared to treat depression, drug-resistant depression. And that was a one protocol, one size fits all approach. You have depression, you go in and you receive a treatment, a set protocol. This is MeRT, which is EEG-guided TMS. So it is the same stimulation, but the difference is the protocol. The protocol is developed from the EEG from that individual's brain. Yeah, so you take that information and create a protocol and yes, and target the locations that you need to target.
Okay, so TMS doesn't do that.
TMS is only FDA cleared for depression. This is using TMS off-label for other indications because we are doing a more personalized EEG guided protocol. We start usually with a 2-week trial. So we want to see, is this going to help this individual? So we start with a 2-week trial. It's Monday through Friday, every day for the first 2 weeks. So it's a daily treatment. So it is a big commitment. It requires someone to come in every day. And we do the first 2 weeks. We see if there's a change between the baseline EEG and the 2-week follow-up. If there's a change, if we see EEG changes and we see corresponding clinical changes, we'll recommend that you continue for another 4 to 6 weeks. Because we know, yes, 2 weeks we'll see changes, but it takes about 6 to 8 weeks for it to stick and for it to be durable.
So you're saying 4 to 8 weeks of every day?
Every day, Monday through Friday, yes. And after the first 2 weeks, if you have to miss a day here or there, that's okay. We can make up for it at the end. But the first 2 weeks, we want it consistent every day, Monday through Friday. This is not our TMS, MeRT, they are all non-invasive forms. There are invasive forms, and those are used to modulate. I'm sure you've heard of Parkinson's. Neurosurgeons have used implants to control movement and behaviors. That's all neuromodulation, but that's a separate form of invasive modulation, neuromodulation, yes. So we'll see, particularly in autism, we see a lack of development of alpha in the frontal brain. So we saw that kind of that flat part of that graph. And so all we're trying to do is we're stimulating that part of the brain, and we're trying to develop activity in that frequency range. So we set the machine to a certain frequency, we stimulate the brain, we send a magnetic field and we pulse it at the set frequency specific to that individual, and we retrain those neurons to start firing in sync with that magnetic field. And then we'll start to see changes on the EEG. We'll start to see a pickup in the frontal regions, especially with autism. And it's different with other disorders that we treat. There are different EEG patterns that we see, but this talk was kind of geared towards autism.
Okay. Gets everybody in there on the same page.
Gets everyone on the same page, exactly. And communicating at the same speed, exactly. We have had patients who've done 7 days of treatment. It can increase side effects a little bit, going that many days without a break. But we do have patients who will go 7 days. Yeah, and we haven't really done 3 days. We have patients who do 3 days, if they just can't make it or they're traveling, we have them, they might have to skip a week. We just don't want to skip it during those first 2 weeks because we really want to see if this treatment is going to be effective for them.
Yeah, I went and saw Stacy through September and October, and did 3 days a week for 8 weeks. What was it, 7 or 8 weeks? And I did it like 3 to 4 days a week. And my EEG at the end was actually still really good, much improved. So I just thought that was kind of an interesting thing, because I just couldn't make it to Cardiff.
Of course. Of course. And we have patients like that as well. So yeah, and we will take what we can get. Maybe a little bit slower progression, but we all get to 8 weeks. So yeah.
Cool. Thank you.
And we would count it more towards the number of treatments. So it may have taken like 40 treatments to cover 8 weeks, but we would still cover it over an extended period of time.
Gotcha.
Yeah. So when we first started, our average age was just about 7 years of age. As more and more people know about us and or hear about us early, we have children as young as 3 who come in. And so the earlier that we see them, probably the better. Early intervention is always ideal. But we do have adults with autism as well that we see, and we see good results in them as well. Yes, and I think we need more studies, especially with FDA clearance. It requires, large cohort of patients and big financial backing to, support that study. So we hope one day that we can find someone to do the study with us. Yeah, at this time, the cost is prohibitive for for many people. And we hope that we can decrease the cost over time. But for now, we haven't been able to get it covered by insurance. And that is our hope as well. But yes, San Diego is our sister clinic. Most of the staff here started in Newport. So same staff and same. Yeah, and a lot of these people, I'm from Newport as well, and we're all from Newport. Yeah, so I'm glad you chose this clinic. Yes, so the protocols all come from Wave Neurosciences. Each clinic, has opened a different time and are owned by different owners, but the treatment itself, the protocols, are all delivered by Wave.
How can we be assured that each clinic is following exactly the same protocol for the safety of your patients?
So we have a training process in place. I say we because I'm part of the training team, but there is a training process in place at Wave to train both doctors, clinicians, and technicians. And it's pretty extensive training that the technicians and clinicians go through to deliver MeRT, and they have to pass certain exams to qualify to deliver MeRT treatment. There was a transition when there was a platform called MeRT 1.0 to MeRT 2.0. So it's not a difference in the protocol, the treatment being given, but the output of the reports did look different. So there was a transition of a year that all clinics converted to MeRT 2.0. Newport Beach was the first clinic to convert. And so the EEG reports did look different for a while as all the other clinics. But Newport and San Diego are one and the same. We share the same medical records. We are the same clinic, same owners. No difference between Newport Beach, San Diego, and Cardiff. The answer to that is yes. So they've done so many EEGs. As long as they have a certain, even 20 seconds, 10 seconds of segment, they can calculate the protocol for that patient. The reason why we record for so long is not for the protocol, because that can be gathered pretty quickly. It's for the report. To generate a report, we need a certain amount of clean data. And that's why we're recording for 10 minutes instead of, just a couple of minutes to get that protocol. So that's, like a quick answer is yes, we can get the protocol pretty easily, but the reason we record much longer is for that report, because it is an objective measure of how patients are responding.
At home to put the shower cap on or whatever to practice at home.
Yeah, it does come in handy, and even then you put them in the room and it's a different scenario. But we do recommend trying to do some practice, and I understand it's difficult to put that cap and sit in a dark room.
Their ears.
Yeah. Yeah, if we can confirm that, or if we can get, cochlear implants were a contraindication. They've been, and it's still on our list. But I wonder if they're using different metals currently than they used to use. As long as it's titanium, and we would have to find out from probably the surgeon who put it in. It's a possibility it could be used. Right now, it's still on our absolute contraindication list because they weren't made of titanium before. But if we can find that out, there's a possibility we could still treat. And if it's not there, then we can definitely treat.
Okay.
Yeah.
They need more treatment.
Yeah, and so the study that we did, the double-blind study that was done, I wasn't a part of that, but that was done. It did show that there was no loss of benefit in 2 years follow-up. But many times the way children with autism respond is we see an improvement, and it's a stepwise progression. We see an improvement and then a plateau, and then parents want to see if they can get more from the children, and then we stimulate again. It's not that we lost benefit, but really to see, okay, so last year we did treatment and we got this much. What can we gain this time? And we have patients who come every summer for the last 5-6 years. And so,
And there is a benefit.
and each time they gain something more. And they come back not because we told them they had to come back, because they want to come back. And so each time they're seeing different benefits. The cost is $8,000 per month. So per month.
It doesn't matter how many treatments go in that month.
20 treatments, 3 clinical evaluations, and 3 EEGs in that month. So yeah, you do your baseline, and then every 2 weeks an EEG and clinical. The initial clinical is to evaluate, make sure you're a candidate for treatment. And then the baseline EEG, 5 treatments, then another, 10 treatments, and then another EEG, another clinical to decide if we're going to move forward. But it comes out to about $400 per treatment, and pretty much no cost for the EEGs and clinicals. That's kind of how we package it. Yeah, so when we look at people with high beta, and we see a lot of that, a lot of times if the alpha is disorganized, the beta predominates, and people feel overwhelmed, people feel anxious. As we increase alpha, we increase the relative amount of alpha, and the relative amount of beta decreases. Patients feel calmer. Parents tell us the patients are calmer. Adults tell us it's not so busy in their head. When they lay down to sleep, the thoughts aren't as busy. So yes, it would probably start with an EEG, see if there's, see what that alpha disruption is, because that's usually the root cause. And then if we can increase the amount of alpha, which drops the relative amount of beta, that's when we see improvement in that kind of that overactive behavior. That's a great question. So no, there's no contraindication to medication. There are some classes of medication that may slow down the response, and those are benzodiazepines, anticonvulsants, and a medication called baclofen, which is used for spasm. But even if patients are taking those medications, it doesn't mean they have to stop. It just means the response may be a little bit slower, but we usually see response even in people who are taking those medications. So there is no absolute contraindication medication that's out there. Thank you all for sharing and being so interactive. It makes it, not just one direction. And I'm sure it's great for all of you to share and hear your stories. And I really grateful that both of you shared your experiences. All right, well, thank you all. If you want to stay, if you haven't toured, you can tour or hang out and talk to me or Kaylee, and we're happy to stick around and answer any questions.